And very grateful to Dr. Ramakrishna sir, who is a professor and also is a great academician, a researcher, a clinician, and also our Indian Journal of Gastroenterology. He was the chief editor, then also the Tamil Nadu Gastro Journal. He is taking care. Very grateful to BSR sir for chairing this session, and we will have a lot of pearls of wisdom at the end of these two talks, and then we can have a question answer session after that. So today I'm going to talk to you about functional dyspepsia. So especially postprandial distress syndrome. For that, we should understand what is dyspepsia. Dyspepsia came from the Greek words, two Greek words, dys and pepse. Dys means difficult, and pepse means digestion. So wherever there is difficulty in digestion, it's called dyspepsia. So it's popularly called as indigestion. This you would agree, all the viewers would agree, this is one of the by far the most common problem that you and I see in our clinical practice, in day-to-day clinical practice. So this is very important for us to understand this disease so that we properly treat. So dyspepsia is a chronic, or recurrent upper abdominal pain and or upper abdominal fullness and feeling full earlier than expected while eating. Like, you feel full. This is called early satiety or satiation, we call it. So, what is functional dyspepsia? Whenever there is somebody with dyspepsia, the first thing that you have to rule out is an organic cause. Can we find a cause for dyspepsia? Especially so in above 45 years age group in India, above 50 years, elderly, and with family history of cancers or patients with abnormal weight loss and anorexia and vomiting of blood, all those situations, we need to rule out any organic cause. So first we have to rule out organic cause. Once we do the basic workup like ultrasound and endoscopy and all that, and some labs, you don't find anything, but the patient has dyspepsia, then it's called a functional dyspepsia, where no organic cause can be found for the symptoms of dyspepsia. And the functional GI disorders are very common. And if you see the FGID, the functional gastrointestinal disorders, you see the India map is really in the 15% to 19% map. So we are one of the highest in the functional dyspepsia when even compared to some of those North American countries. So the functional dyspepsia, we always follow the Rome Foundation criteria, the Rome 4 criteria, which means, which defines it as this: bothersome postprandial fullness, bothersome early satiation, or bothersome epigastric pain, bothersome epigastric burning. So, and this with no evidence of structural disease, including an upper endoscopy, that is likely to explain the symptoms. You don't have any structural disease that can explain the symptoms. And these criteria must be fulfilled for the last 3 months with the symptom onset 6 months prior to diagnosis, which means somebody should, a patient comes to you, the onset of the symptoms should have been before 6 months. And at least for the past 3 months, the symptoms should have gone on. So then you can classify this as functional dyspepsia according to Rome. So the first group is called a postprandial distress syndrome, PDS, about which we'll be, discussing more. And the second group is a classic epigastric pain and burning, just like, like peptic ulcer disease, where the patient presents with pain and burning, and with PPIs or PCABs, the patient finds relief. That is but endoscopically, you don't see any ulcer. So, or any other cause. Postprandial distress syndrome, at least 3 days a week, the symptoms should be there, according to Rome 4. Onset 6 months prior, and at least for the last 3 months, this should have gone on. And at least 3 days a week, the symptoms should exist. So, in epigastric pain syndrome, the EPS, which is hard, I mean, the epigastric pain and burn, even if one day a week the symptoms are there, that is enough to call it EPS. So PDS and EPS. These are two components of functional dyspepsia. And remember, this is exactly what we spoke, but there is an overlap between PDS and EPS. So this is to be remembered always. So these are not watertight compartments. So patient presenting to you may present with epigastric pain, burning, may also have postprandial bloating, so or postprandial distress. So remember, these sort of combinations can always happen in real life scenario. Then we'll have to treat it according to their symptoms. So what are the risk factors for functional dyspepsia? Age, infections, dietary factors, smoking, alcohol, non-steroidal drugs, and psychological associations. Say age, especially the younger age, they're so anxious and nervous, and they can keep swallowing air. And also they eat food outside, can pick up infections. One another important cause in India is the H. pylori infection, and the H. pylori keeps generating a lot of acid. And this acid, when it enters into duodenum, the hydrochloric acid, has to be buffered because the duodenum cannot bear the brunt of acid. So what happens is the duodenum, the Brunner's glands secrete sodium bicarbonate in order to alter the pH in the duodenum so that the duodenum doesn't get burnt out or digested. So the HCl and NaHCO3 combine together to form inert sodium chloride salt, which just goes down, and water and carbon dioxide. And this carbon dioxide can bloat up the patient. So the dietary factors also, the so-called FODMAPs and high-fat diet, all can increase the gas production in a lot of individuals, and even lactose intolerance can lead to gas production in a lot of people. So, and of course, smoking can trigger, acid production. Of course, alcohol and non-steroidal drugs can produce gastritis. And of course, the psychological associations, the stress and anxiety are very important. I'll talk to you about how the importance of PDS and the stress and anxiety is now the association is very clear. So, how does stress produce functional dyspepsia? The stress causes release of CRF, the corticotropin releasing factor from the hypothalamus. And this leads to increased expression and release of neuromedin U in the medulla. And this inhibits the food intake and delays the gastric emptying, alters the GI motility and sensitivity, and produces an impaired accommodation. I'll tell you an example. You're going to all of us would have faced the medical university exam. When you're going in the morning to the exam hall, either your mother or wife would have made nice dosas. She'll say, take dosas or rotis and go. You'll be able to eat only one roti or one dosa. It says, no, mom, my stomach feels full. I can't eat anymore. Why? Because you're stressed. So, but once you write the exam so beautifully and come back, even a whole plate of Hyderabadi biryani would go in without any difficulty. That means there is something called a fundic accommodation. The fundus is the receptacle, and the receptacle has to expand to receive food, the upper portion of the stomach. And that doesn't happen if you're stressed. So de-stressing is very important. Or you can improve the accommodation with drugs like acoshamide. Sure, Madhura will be speaking about acoshamide. And it's a beautiful drug, particularly for this indication. So the pathophysiology of functional dyspepsia is manifold. One, there may be a gastroparesis or a functional outflow obstruction at the pyloric level causing delayed gastric emptying, or there could be impaired accommodation as we described just now, or there could be hypersensitivity, H. pylori infection, or even central nervous system dysfunction. All can produce dyspepsia. So it is very prudent to properly evaluate clinically all these patients to find out what exactly is happening in a given patient. This is what I told. This is a pictogram which shows that whenever food comes in, the cardia should expand like this. Then it can accommodate more food. If it cannot expand, then with very little food, the stomach will say full. This is one of the ways by which we, tackle obesity. We, through endoscopy, we do this sleeve gastroplasty, ESG. We reduce the fundus and the proximal corpus. We reduce the space where food can be stored. So even with little volume of food, the stomach will say, I'm full. So that produces satisfaction. So the appetite and satiety centers are reset. And so patient is satisfied with the small quantity of food. So we'll have to use small quantity of food in multiple small aliquots, through the day. Instead of 3 meals, you can make it 6 meals, small quantity. Then they'll be able, the tolerance will be better. Otherwise, the fullness can produce nausea and can trigger even pain or discomfort in the abdomen. So, impaired accommodation in a study by this author, Bredinoon. So, they showed that 47% of functional dyspepsia have an impaired accommodation in the stomach by means of the SPECT. In a study with funtic barostat, impaired accommodation was shown in 40% of patients with functional dyspepsia, and it was associated with symptom of early satiety. So, my friends, if some patient comes to you with functional dyspepsia, where you ruled out all organic causes, then if you label it as functional dyspepsia, 40 to 47% of these patients have an impaired accommodation. That has to be remembered. So some pictograms to show how to show the patient pain or burning. You can have all these pictograms in your office so they understand what you're describing, especially what is this early satiety. So they say, we feel there is a rope tied around the stomach. Stomach doesn't expand. I can't eat much. And postprandial fullness, people say that there is some weight kept in the stomach. That's how I feel. So these are simple pictograms which can tell you how to, differentiate. And again, bloating and distension are two different things. Distension, the flanks distant, and the bloat, the anterior abdominal wall distance with the diaphragmatic descent. So that is beautifully, like shown today with the SPECT, studies and with pictures beautifully defined. So some people may have both visible distension, measurable distension, as well as the bloating. So all these can happen. So in a clinical patient with dyspepsia, is it epigastric pain or burning? Then it is functional dyspepsia, EPS, the other group, which is just like ulcer disease, but endoscopically there is no ulcer. This is called originally, like those days when we were students, it was called Moynihan syndrome. So now this is functional dyspepsia, EPS. The PDS is what we are looking at, which produces impaired accommodation, early satiety, bloating, and or distension. So these can overlap, as I told you very clearly. They're very common in overlap. That makes the diagnosis very challenging, impairs the quality of life. Interestingly, GERD can overlap with functional dyspepsia, and 63% of functional dyspepsia patients can have a GERD overlap. So that also patients can have reflux and heartburn. So again, between PDS and EPS, I showed you overlap is up to 62%, which means you have to use multiple drugs to get all these symptoms abated. So I'll show you some clinical capsules. This is the 35-year-old lady who presented with epigastric pain of 6 months duration, associated with heartburn, bloating, postprandial fullness, and occasional belch and early satiety. You see, the patient has one heartburn, GERD, epigastric pain, which is EPS, and then the bloating, postprandial fullness, and belching and early satiety, which is PDS. All three are overlapping in this case. So we need to rule out everything. So we need first the ultrasound was done, which was normal, and urea breath is a negative, and upper GI endoscopy was suggestive of laxilius corporal antral gastritis, RUT was negative, and this is not UBT. At that time, ammonia breath was ABT was done. So electrogastrography showed poor myoelectrical activity, which means less than 5 interstitial cells of Cahal per high power field, and there is a gastric dysmotility or a poor gastric paresis, having the poor gastric motility indicating gastric paresis. and GMAT score was -3, which means there is no functional outflow obstruction. Lactose breath test was normal. So we did the whole workup, and this ammonia breath test, which is negative. This is the endoscopy. There's no hiatus hernia, but mild laxity of LES. If you see the brown coloration inside the blue-green, it indicates there is some reflux that is happening. And then the pylorus was tight here. So look tight here. So this is what it showed. So if you see here, this is less than 5 per high power field of ICCs, which indicates that the motility is poor here. This is the upper normal community range. There's a lower normal community range, and the blue is the patient's line. This is the 3 CPM activity, where this line has to be well within the two red lines. It is much below, indicating there is a dysmotility of the stomach. So this is there is a gastric neuromuscular dysfunction with ICC deficiency with poor gastric bioelectric activity. So lactose breath test is normal. So dyspepsia, EPS plus PDS. So patient was started on PPI, which could take care of the epigastric pain, acocimide, which will increase the early satiety, amitriptyline to reduce the distress and the you know the anxiety component of the patient, and the patient could do well. So also these sort of combos are very important whenever we look at these patients of functional dyspepsia. So we'll have to rule out H. pylori, gastric motility, visceral hypersensitivity, psychologic factors, all have to be looked at. And then all these, even PDS, IBS overlap can happen. So FD constipation can happen. So all these are dysmotility disorders of the gut. So what are called the FGIDs, the functional gastrointestinal disorders, where the mind and the gut have an interactive role. So we need to look at the patient as a whole, evaluate completely before prescribing a drug. So this is an algorithm which shows if there is a patient with functional dyspepsia, first test that I would do is H. pylori test, eradicate it if it is not done before. And this test can be done by urea breath test. 13C urea breath is available here. Now in India, again, 14C has come back with some radioactivity. Ammonia breath test is available. And then fecal antigen test is available. Or endoscopic biopsies and the CLO test or the rapid urease test can be done. Once H. pylori is eradicated and you do a dietary modification, sometimes, even FODMAP diets for IBS and low spices, oily foods to prevent reflux, and, high fat diets can delay the gastric emptying. So all those modifications, lifestyle, dietary, after that, if still based on the predominant symptoms, you can divide into EPS or PDS. If it is EPS, the proton pump inhibitors or PCABs are useful with or without prokinetic agents. Whereas here in PDS, prokinetic agent is the primary thing, with or without proton pump inhibitor, depending on how much component of EPS is there or PDS is there. So if there is response, continue. There is no response at 4 to 8 weeks, recall the patient and try antidepressants, anxiolytics. And this was one of the studies which said herbal medication. Out of the herbal medication, one thing is very important medication is asafoetida, which is in Tamil called perungayam. This has got asafin resin. This improves the gastric emptying. So it's one of those churans, the Ashtachurans and all had this asafoetida. So which helped in preventing nausea and also in allowing the emptying of the stomach whenever somebody felt bloated. And I'm not joking. My mentor in the United States, with whom I got trained in 1987, he uses asafoetida capsules in these patients of functional dyspepsia even today. That's interesting. So if we cannot find a solution, we need to do more work upon these patients. Another case after which I'll close, 26-year-old male who presented with postprandial fullness, early satiety. She is not able to, even with little small meal, he's able to feel. He gets filled. And then this is how the endoscope look. There is some reflux also. And one thing that can be done, and this looks tight here. So all these are there. So we did electrogastrography. You see here, This is this graph is going much above, indicating high GMAT score. So, and a functional outflow obstruction also is there. There is a delayed gastric emptying because of functional outflow obstruction, treated with prokinetics, but a balloon dilatation will do. And I would really recall here seeing a patient who was treated by Dr. B.S. Ramakrishna 7 years back. He had diagnosed this problem. There was no EGG, there's nothing. And he had diagnosed and did a pyloric balloon dilatation 7 years ago for this patient who did well. And he came back to us later, much later on after 7 years. That is a clinical acumen professors like Dr. Ramakrishna have. So, how to manage GERD I told you, PPIs. If there is EPS, if there is more of PDS than prokinetics, PPI and a prokinetic is a winning combo for GERD and functional dyspepsia overlap. So what are all the prokinetics we have? Here, the prokinetics accelerate emptying and improve the motility of the esophagus and the stomach, increase the LES pressures to prevent reflux. So they prevent reflux and produce a prokinesis for the food to move down. So domperidone is one of those. All these drugs are good as prokinetic agents. But as I told you, it is the acoshamide is the one drug which can really help. And this both GI and central, and it's superior to placebo in addressing FT symptoms. And Madhura is going to speak more about this drug. So these are all the prokinetic agents, but this is something special. And for postprandial distress syndrome, uh, the one drug that is very useful is acoshamide. This is my last slide. So unsatisfactory response, refractory current treatment, we have to look for new options. These are unmet needs. And currently available prokinetics do not address sorry for the spelling mistake, fundic accommodation. There's a Western concept because they do not have acoshamide in the US. It's came from Japan to us. So it's Southeast Asia has it. It's a beautiful drug and it has got a central action also as I was talking about the neuromedian U pathway, and it's very safe. So choosing the right prokinetic, see here, acoshamide, pure PDS with classic symptoms of early satiety and bloating immediately after meals. That is the place where acoshamide will be a winner. And so to summarize, upper GI dysmotility have significant prevalence in clinical practice, hampering quality of life. Significant overlap exists between these disorders, GERD, EPS, PDS, and even IBS, makes the diagnosis very difficult. Prokinetics are drugs of choice, and the safety profile of prokinetics plays a critical role in choice of the right prokinetic. But acoshamide is something unique. We have written in this book on acid peptic disease. There's a beautiful chapter on functional dyspepsia. So I stop here and thank one and all of you for the patient listening and to Lupin for giving this opportunity. And I hand over the mic back to Imajika and Dr. Ganjan. You can take over, sir. Thank you.
Thank you, Dr. Vijay Mohan, for taking us through the diagnosis and diagnosis of the functional dyspepsia and postprandial distress syndrome in great details. Now, I would like to invite our second speaker, Dr. Madhura Prasad Suman, who will talk on the clinical evidence supporting acoshamide use in functional dyspepsia and PDS. Over to you, ma'am.
At the outset, I would like to thank Lupin for this wonderful opportunity and Dr. Ramakrishnan sir for his kind words of introduction. I'm here, I'll just start to show all the different studies which have supported this use. I hope you can see my full screen?
Yes, ma'am.
Yes.
Okay. So with the beautiful introduction about FDPDS by Dr. Mohan Prasad, I would like to go in with just a general case report where we would use acoshamide. So this is a 42-year-old, a female office worker with a normal BMI who started having symptoms 6 months ago of postprandial fullness, early satiety and bloating, typically worsening after a meal and immediately after a meal. And with no alarm symptoms, they have tried PPIs and domperidone for 4 weeks, minimal relief, and normal bowel habits. So with this, what does she have? She has bloating, and she's immediately after eating, even a small meal, she feels bloated. So if you look at functional dyspepsia, we know that it is not a simple problem. As Dr. Mohan Prasad was explaining, right from H. pylori, we have to really sit with them over multiple sessions to know if there is a gut-brain problem with the emotional and a functional component, along with the altered gut microbiota. And right now, the duodenal mast cells, eosinophils, there are so many things, right from bacterial overgrowth and colonic inflammation. So with the basic investigations of this lady, within being normal limits, we would like to term her as a postprandial distress syndrome, and meeting Rome 4 criteria, and knowing that she has normal investigations. So, having a postprandial distress syndrome with with just a small meal, it's good to try acoshamide 100 milligram thrice a day before meals for 4 to 8 weeks, and she actually did well. And with a low fatty diet and maybe a little less spicy diet and any concerned foods increasing her bloating, we tried to help her out. So she improved, and there was marked improvement in fullness and early satiety. And then she was able to eat normally. Why does this help? Because acoshamide helps to target postprandial symptoms because it acts on gastric emptying and accommodation. And it's effective in, okay, let's say this one thing is one indication where we have found it to be useful, with even a small meal results in a bloat. So looking at why do we have to go over all these algorithms, even though Dr. Mountress has spoken about this, is because it's that important. So EGD, if there's any alarm signs, EGD plus biopsy if those who fail to respond to standard therapy, and then postprandial distress syndrome and epigastric pain syndrome, we classify it. And we know that PPAs work excellently for EPS and partially for PPDS. And diet, exercise, avoidance of triggers, and doing yoga helps with pranayama. And if there is still a failure, then we're trying prokinetics, knowing that many of them have a lot of side effects and we cannot use them on a long-term basis, going for acid suppression again. And then thinking about tricyclic antidepressants, other medication like psychotropics, and finally a trial of rifaximin. It goes on. So these are all the things we are thinking of: the gut, the brain, and then the microbiome, and the other factors like eosinophilia or H. pylori infection. So going over, we know that the level of evidence for prokinetic is low, and still we are relying on multiple of other therapies like H. pylori eradication, PPIs, H2 blockers, mucosal protective agents, prokinetics, and TCAs and psychological therapy. Now, as PPIs for EPS, we would say that mosapride was tried and was not found to be superior to placebo. Positive results were found with itopride for a phase 2B, but it was not superior to placebo in phase 3 trials, though we do find some use with all these drugs. We cannot give it long term. Now, there is an unmet need, and that is where we are here with acetylcholine, which powers GI, and acoshamide being the drug. It's a cholinergic, and it increases the gastric fundus accommodation. So the stomach receives the food and also increases the gastric antral motility. And this acetylcholine results in restoration of the fundus stone and gastric antral motility. Now, if you see acoshamide, where does it act? Now, this is the cholinergic nerve ending, and that is the smooth muscle. And acetylcholine is released, and it sits on these receptors, cholinergic receptors. And there is an auto-feedback, negative feedback, where the same acetylcholine causes an autoception, or sits on these autoreception receptors and blocks these M1R and M2R. I wonder if you can see my mouse. So there, it blocks it, and once it blocks it, acosamide, what happens? This negative feedback is blocked, and continuously acetylcholine continues to flow, and this is how it acts on the presynaptic M1 and M2 autoreceptors in the enteric nervous system, and thereby increases the acetylcholine and increases the motility. It also acts by inhibiting acetylcholinesterase activity, and that will, when the cholinesterase is blocked, then more acetylcholine is there and hence more activity. Now, it was first developed in Japan after researchers observed that certain acetylcholinesterase inhibitors improve the gastric motility alone without having any effect on the systemic like neostigmine and pyridostigmine. And hence, acosamide came, being very selective and a gut-specific prokinetic. And a long-term phase 3 trial was completed in Europe and phase 2 in USA, and that is when it came in. And they found that it had no affinity for 5-HT4 or dopamine receptors. And if you look at the mechanism of action, it has a peripheral and central action. Though we do think more of the peripheral, it being a prokinetic and a fundic relaxant. We should not forget that there is a central effect also. Let's have a look at what is accommodation. So when food comes into the stomach should dilate to receive it, and that is accommodation. And that starts right when the food comes into the oral cavity and the food pipe. Even then, the stimulus goes in through the vagus and through the brain and vagus, and that is the receptive relaxation is the first step. Next, what happens is once the food enters the stomach itself relaxes based on the stretch. Stomach stretches and then it relaxes, and that is adaptive relaxation, and there all these nitric oxide, ATP, VIP play a role. So, acosamide addresses this impaired accommodation and helps to restore this back to normal. And how does it do both? So we know that accommodation is actually an inhibitory and relaxation, whereas antrum, it increases the motility. How does it happen? Excitatory motor neuron is stimulated and it increases the GI motility, whereas it also, the interneuron, based on the interneuron, inhibitory motor neuron is stimulated, and that's why fundic relaxation happens specifically. So we should never forget that the gut and brain are always friends. And that is why we know that here acosamide has an effect on the brain also. It inhibits expression of neuromedin U in medulla, modulating the stress response, and it's also a stress regulator. And about safety profile, knowing that there's no effect on 5-HT4 and also dopamine is very good, but it also doesn't have any cardiac safe. It's very cardio safe, and it's also having CNS safety because there is no QT prolongation even with the highest dose. And CNS safety, there's no extrapyramidal side effects and no action on D2. So, acosamide is approved for treatment of meal-related FD symptoms such as postprandial fullness, epigastric bloat, and early satiety, which are the very classic PPDS symptoms. Usual adult dosage of acosamide is 100 mg thrice a day. And the pharmacokinetics, if you look at it, it has a Tmax at 1 to 1.5 hours and a T-half at 7 to 10 hours. And excretion is by feces through the gut. And there is no QT prolongation and no effect on P450. There are some side effects in some studies like diarrhea, constipation, nausea, vomiting. And one particular study said there was increase in prolactin, ALP, GGT, TGL, AST, total bilirubin, but the other subsequent studies didn't show any such effect. And if you see here, it has some interaction with anticholinergic and cholinesterase inhibitor drugs because it may either increase or decrease based on what it is against. Now, these are all the initial studies which were done, phase 2, and also animal studies. It showed a gastric motility improvement, emptying improvement, elimination of symptoms and PDS symptoms, and sometimes improvement in EPS symptoms, though every study showed that PDS symptoms had improved significantly. So let's look at the studies one by one. So this is a long-term safety and efficacy in phase 3 Europe open label safety trial, where there is now they use acosamide 100 mg thrice a day for 1 year. And the effect, what were they looking at? They were looking at FD symptoms, quality of life, work productivity from the efficacy side. From the safety side, they looked at the adverse events. Now, how do you evaluate these? You know that PDS is such a very complicated thing to judge, right? So there is a symptom scoring which LPDS, which is a validated 8-item score showing satiation, postprandial fullness, and bloating, and also having a bit of the heartburn, belching, and nausea also there. And OTE is what most of the studies use, overall treatment evaluation, where the higher the score, better the improvement. 7 is the strongest score. Quality of life, there is a short form Nepean dyspepsia index, which most of the studies used, and a work productivity index, which we used. Now, when efficacy outcomes, it showed a wonderful OTE improvement, that is overall efficacy improved, and overall treatment evaluation by the patient, it improved. And the improvement increased as time progressed and went up to 70% at week 52, which is very heartening to see that. And PDS symptoms, it also improved, with postprandial fullness, early satiation, upper abdominal bloating. All of them showed a gradual improvement trend, and it increased as time went by. Quality of life also, there was a good improvement, and the mean value of each of the domains improved. The Nepean index also improved. And this absenteeism is the person is absent from work. Presenteeism means they are going to work, but they are not performing well. So that is there. And work productivity loss, you can see a wonderful dip and improvement in all these symptoms. So in conclusion, in this study, 81% continued acoshamide more than 50 weeks, which is a big deal. Most of the time they discontinue, either because they have become fine, or they have discontinued because they feel the drug is not working, or they have some side effects. But here 80% continued, which is heartening to see. And there was no significant ADR, with only 1.4% having nausea, abdominal distension in 1%, and constipation in 1%. There was good improvement as you saw all the scores, and it showed that it can be administered continuously for a year. Long-term study of acoshamide with functional dyspepsia in Japan. This study was for a 2-year period. And 48 weeks at 32 centers for looking at the efficacy, safety, and administration pattern in FD patients. And with this also, there was an improvement, was 26% at week 1, and the OTE improvement increased to 60% at week 8. And the rates of elimination of postprandial fullness, upper abdominal bloat, and early satiation again increased as time went by. Now, here are some parameters which is interesting to see: cessation rate, readministration rate, poor response rate, and remission rate. Cessation means they responded and so they have stopped it. If patient is addressed as responder for 3 consecutive weeks at the time of a visit, performed every 4 weeks. That's a responder. Readministration, if they have become a non-responder and during dose interruption. And the remission rate is understandable. So this is the rate. So FD symptoms started to improve from an early stage of treatment with acoshamide, and it was maintained even after a dose interruption. And many patients resolved even after the dose was interrupted, they continued to improve. And if it relapsed, the symptoms relapse, as our FD patients do come back with symptoms again. And we can see that resumption of therapy, it still works. And the adverse event rate was also very minor. And it was 11%, but they were all minor side effects, and they're mild, except for increased ALT in one patient. So this is another study, a placebo-controlled trial for meal-related symptoms of FD. It's a multi-center randomized placebo-controlled parallel group phase 3 trial. Again, it was given for 4 weeks. And here again, OTA and elimination of the 3 symptom-related symptoms was checked. PDS-related symptoms. And here also, this is a weekly assessment. W123 stands for the weeks. And you can see that there is a good improvement in the overall treatment efficacy. And that was apparent from week 2. So from week 2, you can start seeing gains. So if you treat from week 1 and less than week 2 weeks, I don't think we can see any gains. So going for at least a month or maybe like up to, we can discuss with Dr. Ramakrishnan about how long he would like to give, but up to at least 2 months should be ideal to see some effects. And after week 2, you can start seeing some effect. And after discontinuing acosamide or placebo, neither group returned to baseline within 4 weeks. So they took a 4-week course, stopped for 4 weeks, and they still did well. And this is a collected data from all the gastroenterologists prescribing acosamide. And here, because they wanted to compare, and they had 314 patients of which male is to female was 3:2, 60% were more than 40 years, and 13% were more than 60 years. And this was the symptomatology. Most of them had postprandial turbulence, bloating, and early satiety. And you can see that there was good improvement, and most of them had a significant improvement in symptoms. And also all the symptoms seem to be improving. And those where the drug was given for more than 28 days did show a better improvement. And if you see sub-analysis also, there was significant improvement for bloat, for postprandial distress, and satiety, postprandial fullness, and early satiety. Adverse events, there was palpitation in one, nausea in one, epigastric pain in one, and there was lack of efficacy. They discontinued. Only 4 had discontinued. And some of them had a few things like headache, nausea, vomiting, vertigo, burning sensation, palpitation, epigastric pain, and lack of efficacy. But you can see that there are a lot of overlaps with PDS itself with all the symptoms. And there was significant improvement in 79%, 74%, and 77% of the cardinal symptoms of PDS. And pre-therapy duration of symptoms did not significantly affect the scorings of complete relief. So whether the patient had long-term PDS or a short-term within 6 months, they still improve. And there was good relief when they were treated for more than 28 days. That was something which was useful to know. And the 2-week gastric scintigraphy showed good improvement with gastric accommodation and emptying. And this was nice to see. And this is a phase 2B US study where 3 out of 5 quality indicators showed improvement in the SF NDI score, and mental health component also improved. I guess when PDS improves, the patient also feels, psychologically better. So also that is there. And if you see, this is a meta-analysis, and all of them were in this meta-analysis, all these studies were in favor of acosamide. And if you see add-on to PPI, of course, we don't know first about FD, then we don't know how PPI helps in FD. Now we don't know how prokinetic helps. Now combination is there. It's very difficult to assess, but let us try. So this is 105 patients they had taken. They gave esomeprazole initially, and then 23 still had symptoms in spite of having PPI. So those 23 were treated with a combination, and there you can see 78% achieved overall improvement, which is a very big number compared to, which is a good number, knowing that so many of them will be resistant to treatment. So acosamide and PPI may be effective together in select FD patients with insufficient improvement in PPIs, with just an initial PPIs. So to summarize, therapeutic option for patients with FD are limited, with proven with limited, and acosamide is the first approved treatment for FD, diagnosed by Rome 3 when it was diagnosed that time. And acosamide is a gastroprokinetic with a different mechanism of action, and by enhanced acetylcholine release, and also inhibiting the acetylcholine esterase, and having dual effect on both emptying and accommodation. Emptying, it enhances. Accommodation is a negative, the negative interneurons, and it causes relaxation. Now, this is again, why am I doing the same slide as Dr. Vijay was because this is a very important slide. And when in PDS, there are two things, whether there is, pure PDS with classical symptoms of satiety, bloating immediately after meals. Yes, that is a place where I think we have a place for acoshamide, and others, itopride, for overlap with GERD and EPS. There's no doubt for EPS, PPIs plays a wonderful role, and PPI plus itopride. So, though these combinations are frowned upon, we know that none of our patients can get, not all of our patients can get complete relief. And that is when we have to remember this pure PDS with classical symptoms. We have a place here for acoshamide. And thank you very much. I hope it was useful.